So we're trying to do more craniotomies here at the VA. I think we had done it in times past and had some situations that weren't ideal with kind of postoperative management and making sure everyone was ready to take care of postoperative cranial patients, either tumor or trauma related. And so we're hoping to bring more patients in and do some more of those surgeries. I want to make sure that we do them safely, and all those patients are going to be coming here to the SICU for postoperative management. I know that you guys see a lot of post-op spine patients, which is kind of most of the bulk of what we do surgically here, and have a good sense of what to do for MAP goals and those kinds of things. But I just wanted to give the chance to answer any questions and kind of go over some of the things that we think about for patients after a craniotomy. So quick question, what's people's understanding of what a craniotomy is and like what the indications for it are? What kinds of patients do you think would get a craniotomy?
So a bleed, trauma.
Yeah, trauma, a bleed, definitely.
My background is cancer, so tumor removal.
Tumors, yeah. So that's kind of our favorite craniotomy cases, taking out tumors. It's a big thing. Duke, a lot of reason why a lot of residents come there and things like that. So something that we do very, very commonly across the street. I want to bring more here as well. So tumors, trauma, other things. So another thing is sometimes we need to do hemicraniotomies for stroke patients. So if you have a huge ischemic stroke and you have a very, very swollen brain, we remove the skull just to allow for space for the brain to expand and swell, because unlike other compartments in the body, the brain being in a rigid skull, there's not much place for it to go. So there's a doctrine called the Kelly-Monroe doctrine, which essentially says that there's three things that are in the intracranial space. You got the brain, you have blood, and you have CSF. And so if you have any of those compartments increase, then something else is going to either have to decrease, or it's going to push the brain and cause you to herniate or push through the foramen magnum at the base of the skull. Okay, or at least if it doesn't get to that extent, would cause neurologic dysfunction. So things like blood, those take up more space, so it's going to push the brain either over to the one side or the other, called midline shift, or it's going to push the brain downward, called herniation. There's different kinds of herniation. We can just kind of speak to it in the most broad terms. And then things like hydrocephalus, so we may need to do a craniotomy. Hydrocephalus meaning too much fluid on the brain, too much cerebrospinal fluid, either building up due to poor absorption, called communicating hydrocephalus, or due to a blockage of its outflow due to a tumor, or to a small area of stenosis called aqueductal stenosis, which would cause a backup, kind of like a traffic jam. And so you can get hydrocephalus, which increases the pressure in the brain, can cause dysfunction. So we do it for that. Vascular reasons, aneurysms, which we won't do here just because you need specific neurovascular capabilities. But things like intraparenchymal hemorrhages, so a hemorrhagic stroke. Sometimes we do need to do a craniotomy to just give more space and also to suck out that blood. Not something that we commonly do, but if it's too big and it can't be managed medically, then we may need to do a craniotomy for that, called a decompressive craniotomy. So to kind of go to one of the more common things, we first talked about trauma. There's two specific, or three specific areas that you're going to see in terms of blood. So epidural, that's going to be going to look convex, so it comes outward like this. And it doesn't cross suture lines, meaning the bony sutures, so it's often focal and then bows out and gets very large. Those are outside of the covering of the brain, called of the dura, and so those tend to be due to arterial break. So if someone hits the side of their head or their temporal bone, it's very thin there. And so you have something called the middle meningeal artery, which is a most common cause of epidural hematoma. and that tends to start bleeding, and then you get expansion there. Patients tend to have what's called a lucid interval. So they have their initial trauma, bang their head, then they will report they're feeling great, they're feeling fine, just a little headache, but otherwise doing well. And then 3 or 4 hours later, they're obtunded and seizing, and they can't protect their airway. And so that's due to epidural hematoma. Those ones are usually very rapid, can cause decline. It's pushing on, it's an arterial bleed typically, but you can have venous ones. And so because those can change very rapidly, that ends up being like a level 1 case. We need to take it out. Those can also happen after surgery. If we don't get good hemostasis, patients can develop epidural hematomas, which I think is actually what happened to the one of the last craniotomies that we had done here after a tumor surgery. Patient developed an epidural hematoma, and then we didn't have any operating room to get the patient down to fix the problem, and so Dr. Cook had to come and evacuate it at bedside, which is not ideal. But you just have to open the bone back up and it's all out and get that blood out. Okay, and then there's subdural hematomas, which mean under the dura, and those tend to be more devastating long term because they're causing compression on the brain parenchyma itself rather than just pushing things out of the way. And so there's usually underlying brain damage associated with those. That's in a trauma situation. You may see small, tiny subdurals like this. This isn't that bad. But you may see that after a craniotomy, and we would just say, oh, it's fine, we'll get a repeat image and see it, it's not going to cause a problem. But this sign here, where the brain, so this line should be straight down, you can see things are bowed out and pushed out over to one side. That's called midline shift, and that's a bad sign. We don't want the brain to be pushing. And so things that we look at, if this blood product is bigger than 1 centimeter or this shift is more than 5 millimeters, those are operative criteria to need to take a patient and decompress that area. So we look at the size. Then you can have intraventricular hemorrhage, which is kind of here, where there's actual blood in the ventricle, and that can cause hydrocephalus, and often that will decrease the ability for the cerebral spinal fluid to drain out, and so then we have to do external ventricular drains and things like that, the EVDs that you may have seen every once so often. And then IPHs are intraparenchymal hemorrhages, actual bleed inside the brain tissue itself. And this is what we call a fluid sign, or fluid level. So if you see this, that means that there's active bleeding happening. So it's that patient is still bleeding, and it would be concerning that it would continue to expand. So those are some of the things, and imaging-wise, that you would look for, and we would do a craniotomy for these patients. Typically, the different kinds of surgeries that you can do. So we just recently had one of these patients here that underwent burr holes. So if you see that, that's usually done for chronic subdurals. So the bright stuff that you see on the CT is acute blood, but when it looks dark on there, then that is usually chronic blood. And so we often try to wait until those subdurals are chronic if we can. This kind of describes here. We kind of try to wait till those are chronic if we can, because it becomes the consistency of motor oil. So we can do a small opening, small tiny burr hole, just taking a drill like this, opening up the skin, taking off the covering called the pericranium that's there, and getting down to the bone, and then we just drill a hole about 1/4 size into the bone, remove that, and then underneath that we would see the dura. We open up the dura, and then the blood usually geysers out, and then we wash it out with fluids, and we put a drain in, usually a subdural drain right underneath there. We just tuck it underneath if there's space. Sometimes we will just put it on top of the dura because now it's in communication. So if patients come back, like the one we had a couple weeks ago, we did a subgaleal drain. That just means that it's beneath the bone, and beneath the galea, which is a fibrous tissue that we use to suture back the scalp together. That's on top of the bone, and that is now in communication with the subdural space. That we sometimes do, even in other types of craniotomies, but a subdural drain means that we go through the bone flap and we actually put it underneath the whole of the dura, and that's the drain is laying on top of the brain tissue. You have to be careful with those, because if that pulls out, if the patient gets agitated or moves around or it gets stuck somewhere, or someone forgets and doesn't put it in their bed when they're walking to the bathroom or something like that, and that gets pulled, that drain's going to drag across the brain tissue and cause worsened bleeding. So you have to be careful with subdural drains. And so sometimes we'll put those, and that just means that we can do tiny openings and put the drain. They lay flat for a couple of days typically, because when air gets into the brain, it can, again, it's a closed space. The air can cause mass effect and push things. People tend to get pretty loopy and confused and sleepy if there's a lot of air on the brain. To fix that, often we'll have them lay flat, and we'll put them on 100% oxygen, just like a face mask. And that the hope is that the extra oxygen will help push the normal air, which is lower percentage of O2, out, and allow the brain to refill back and get rid of that air. The evidence on whether that actually works or not is not great, but that's something that's commonly done. At least laying them flat is hoping that gravity will help get the air out from there.
This is the air that was entrained during the procedure, right? Once the drain is on.
Correct, yeah. So once the drain's in there too, the drain is also draining things down, and so you increase the amount of space. And so if let's say the skin wasn't closed very well, or if we didn't wash out the air, we usually try to fill it back with fluid, because now you've removed this big clot. There's open space there. You need to fill that with something. So either the brain will expand back to where it needs to go, but if the chronic subdural has been there for a long time, there's usually a gap left there. And so we fill that with saline. And that doesn't cause a mass effect, but if there's air there, it can be agitating to the brain tissue. And then the other problem is if you close it enough, but there's a tiny opening in the skin, that acts as a one-way valve, so air is getting in but it's not getting out, and that can cause a tension pneumocephalus, which can be very dangerous. And that, when on imaging, we see called the Mount Fuji sign. So the Mount Fuji sign is what you see here, these twin peaks. So all that air that's gotten in there is pushing the brain to the point where it's all compressed, and that actually, if it gets severe and the patient's getting sleepy and things like that, we actually need to intervene on, sometimes at bedside, put another hole in the skull and just put a needle in there, kind of like doing a tension pneumothorax in the chest, but you do it in the head to relieve the air from that area, because it can get under tension. That's usually when there's a one-way valve. Not something we always see, but something that we always worry about. And so you'll see the two frontal lobes peaking there. You can see that in all these pictures here. It's called the Mount Fuji sign.
And sorry, this could also be a complication of sinus surgery or transplants, right?
Exactly, yeah.
So benign ENT surgery.
Mm-hmm. Because the cerebral spinal fluid is leaking below, and so then it's now in communication with the outside world, and so you can get air trapped in as well. So things to look out for. Any questions so far? Okay. So we talked about subdural drains, subgaleal drains. The other drain that we put in is the external ventricular drain. So that's another one you have to be careful about, because that's something that we just put into the ventricular space. And sometimes we'll do these after craniotomies, or even if just in the setting of somebody being obtunded and not getting a good neurologic exam, we'll do it. This is kind of a good picture. So this is something we do at bedside, blindly, essentially using anatomic landmarks. We use what's called Coker's point. Essentially, if I put my hand on someone's head with my index finger at their, it's called the nasion or the glabella, it's just right at the top of the nose, and then put it backwards. Where that curve is usually about 10.5 backwards and 2.5 to 3 over, or the mid pupillary line, and we use that to localize the Koger's point, and then we just aim towards the middle of the eye here called the medial canthus, and that should get us into the ventricular space and allow us to get the fluid out. It's about a 3 millimeter space often, unless the ventricles are really big, but you're aiming for the center of the skull, called the foramen of Monroe, where it's draining from these lateral ventricles to the middle third ventricle. So those ones also, you don't want those to pull out. You don't want it to be left open and drop to the floor, for instance, and it drain out a ton of fluid, because if that happens, then it's going to stretch the veins that are on the dura and cause a subdural hematoma, and patients can die if too much of that fluid comes out. So if more than like 30 cc's is consistently coming out over a couple of hours, you want to let the residents know if that's there. Say, hey, should I clamp the drain or raise it, because the patient's putting out a lot of CSF over time. And so you just want to be careful about the outputs. And then this also allows us to measure pressure in the head very accurately. And the number to look out for is greater than 20 millimeters of mercury. That is an abnormal pressure. It's higher than it should be. And so if someone's sustained, what we always look for is someone sustained greater than 20 millimeters of mercury for greater than 5 minutes, then that is something that we need to intervene on, either by dropping the drain, opening it back up, putting it at a different setting, or treating with medicine. So you can do things like 20% saline, or 3% saline, but trying to suck out the fluid in the brain to give more space or decrease pressure, or you can give things like mannitol and have the patient pee it out. Something that is often forgotten, and something that nurses can be very helpful to remind people on, is we commonly will say give the patient 100 of mannitol or give them 23% saline. But the problem is if someone's given mannitol with no Foley catheter in, then they have no ability to get it out, at least not quickly, and they'll either urinate on themselves or they won't be able to have the effect of it, and it just causes problems with their labs. Electrolytes are going to shift significantly, and it's going to be a dangerous thing and not be effective. So make sure that anytime someone's asking you to give mannitol, that they either have a Foley already or a Foley is going to be placed quickly. Any questions? All right, so that's trauma. We talked about brain tumors. So for brain tumors, the craniotomy looks like you remove, same thing, open the skin, open the skull, or the soft tissues called the galea, then get down to the skull. We'll do a craniotomy, so drilling holes, usually with those perforator drills or a smaller drill, removing a large section of the skull. We've set it to the side, make sure that it's sterile. That craniotomy means that the bone will go back. A craniectomy means that the skull does not get put back. And so that's when you see those people come back with like a very sunken head, and it looks like they don't have any space. That's because we decompress, we removed the skull and we leave it off to allow room for the brain. But for tumor surgery, we do craniotomies. So we'll take that off, we open the dura and expand it, and then go down into the brain tissue itself and take out the tumor. And then at the end, the hope is that you stop any bleeding. So things that you guys should look out for if the patient's exam changes. I know Vikram went over the neurologic exam and things to look for. If the patient's exam changes, so subtle things to look for first. Pupils are very important to look for. If you see their pupils getting big, that means that they're pushing on the uncus of the temporal lobe, and that means that it's an early sign of herniation. Or if a subtle thing is called pronator drift. So if you ask a patient to raise their arms in the air and then they start to pronate their hand and drop it, then that's a sign that there's some subtle weakness going on, even if they're giving you good strength and pushing away and able to do all of those things. facial droops looking for, and then just whether somebody's getting extra sleepy and they're not responding to you or they're getting more confused. Those are all things to look for and let us know. And that can happen very quickly. But particularly the really worrisome one is if you notice a difference in pupil size. If one pupil's getting bigger, that's an emergency that we need to intervene on quickly. And usually at least getting a scan quickly to try to see what's going on, because it can be either swelling, it can be blood as the most common problem, or it can just be mass effect that's happening from some issue, and usually that's going to again be blood or swelling. So either you're going to give Decadron to decrease the swelling, or we're going to need to take them back to surgery, or you're giving those things like mannitol or 23% to decrease the amount of compression that's there. One thing I didn't mention, if you are using something like 23%, that has to go through a central line. So someone can't tell you, hey, give a bolus of 23% and you have a peripheral IV, because that's going to blow their veins. You can, for short periods of time, give 1.8% for sure. That's fine to go through a nice size, like larger for peripheral IV. 3% you could do as well, but 23% you can't do that safely. And so someone would need to put in a central line before doing that. What else? After craniotomy surgery, so other than blood, so bleeding complications, things that we would worry about, again, is swelling. So we often put them on a Decadron, and so that's why patients come back. The most common regimen is 4Q6, so 4 milligrams every 6 hours. That's actually a really, really high dose of steroids. Physiologically, people make about 2 milligrams twice, like every 12 hours or so, like 4 milligrams a day is twice physiologic dosing. So 4Q6 is like 1,000 times more than your body normally makes, and the hope is that you will shrink things down. Sometimes we go higher than that, but that's the standard dosing, and then we try to taper that off over time. You want to make sure if someone's on Decadron that they're also on a sliding scale insulin, because we commonly worsen people's hyperglycemia. Steroid-induced hyperglycemia, it can get up into the 400s or 500s if someone has like undiagnosed insulin issues. The other thing is you want to make sure the provider puts on either a PPI or H2 blocker, something to help for GI prophylaxis, because you can have a lot of serious complications with that, particularly because we give such high doses of steroids. So that's something commonly. And then seizures. So if patients are altered, another problem is that the brain does not like blood products, and it doesn't like manipulation or swelling, and that can cause the neurons to fire abnormally, and that can cause seizures. So if a patient's acting, very weird, not always having to have the generalized tonic-clonic stuff where they're shaking out of the bed or any of that, but if their exam's a little altered, that's another thing to consider. If the CT comes back normal, but their exam's still altered, then we'll start thinking about seizures. Is the patient having an issue? And so post-operatively, we often just prophylactically put people on Keppra, is our most common medication. Keppra is really well tolerated by most patients, but it does cause a few things. One of those things is agitation. Certain patients can get extremely agitated. There's the question about whether it can cause like a psychosis, and some data that maybe that's possible, but usually it's just mood instability for people. It can also cause impaired sleep. People have issues with that. And then Keppra can also tank somebody's sodium levels, so you can get hyponatremia from it. So if you see labs coming back, that's one thing to think about or to alert the provider for, to consider. And then if someone has kidney disease, so if their creatinine's bad or they have an underlying end-stage renal disease or anything like that, then we need to dose the Keppra differently, because it's not well metabolized out of the body and can build up. So that's the most common one we use. Other things we may put on is Vimpat or Depakote, or other types of antiepileptics that are common to use. But the Keppra is like that's our favorite one, just because it's pretty well tolerated. Usually patients can eat pretty quickly after a craniotomy, so they should be coming out unless there was a complication or unless there was a tumor that was impairing a cranial nerve that was causing issues with swallowing. They should be able to be on a diet pretty fast. And it's important to do that to get them on early nutrition so that they have the ability to recover from the surgery well and heal. Different attendings have different preferences with when to start Lovenox. So on all our spine patients, all the data shows like there's really very minimal situations or minimal amount of situations where you're not going to start like Lovenox post-op day 1 on a spine patient. But on a craniotomy patient, because bleeding can be such a big issue, sometimes people will do it 2 days later. Sometimes we'll do heparin instead of Lovenox so that we can control it a little better. And often we do a weird dosing where we do heparin just twice a day, so 500 Q12 rather than the typical Q8 dosing. To be honest, there's not really good data of why we do that, but it's just like was done in one paper, and so everybody just does that now.